vector flow mapping, known as VFM, demonstrates flow dynamics in the heart and vessels in a whole new way. Evaluating pre- and post-surgical ventricular and transvalvular blood flow, cardiomyopathies, along with LVAD compliance, are just some of the ways VFM may help you assess complicated hemodynamics and determine surgical strategies. In 1513, Leonardo da Vinci noted the importance and relationship of vortices within the cardiac blood flow. Today, we are able to use our VFM technology to easily evaluate these vortices. VFM uses 2D cross-sectional images obtained by B-mode color Doppler and speckled tracking information in a method to present blood flow as a vector distribution. These vectors indicate velocity and direction as an arrow. The streamlined display is depicted with curved lines connecting the flow velocity vectors as tangent lines. Vortices can easily be seen using these vectors and streamlines. Similar vortex patterns are seen when comparing VFM using ultrasound data, particle imaging velocimetry, PIV, and 4D MRI. In addition to vector and streamlined display, vorticity is another parameter you are able to evaluate. Vorticity demonstrates regional directional rotation and intensity of the vortices using color. Blue moves clockwise, representing the negative flow, and red moves counterclockwise, representing the positive flow. Color density represents the strength of the rotation. IVC vortex. Examining a vortex during the isovolumic contraction period illustrates how the vortex aids in the formation of proper blood flow in the heart by preventing flow separation. VFM can analyze this energy loss within the cardiac blood flow. Blood is viscous and generates frictional heat due to viscosity at the site where turbulent flow occurs. The energy of this frictional heat is called energy loss of blood flow. Using the circulation analysis within VFM, the position, size, and intensity of the vortex is automatically detected and analyzed. Clinical cases. Looking at a normal case, we can see that vortices are produced around anterior and posterior mitral leaflet at early diastole. The vortex by the posterior leaflet disappears, but the vortex by anterior leaflet persists. A diastolic vortex ring appears to function as a temporary kinetic energy reservoir during the pre-ejection phase that supports blood redirection into the outflow tract and generates a force that initiates timely closure of the mitral valve. At early systole, the rotating blood flow is redirected towards the outflow tract. Vortex disappears at mid-late systole, and the systolic outflow is unidirectional and laminar. Intraventricular blood flow is optimized to facilitate efficient systolic ejection of blood. This dilated cardiomyopathy case shows the vortex motion during systole, not moving flow properly into the aorta. Vector, streamline, and vorticity provide further visualization of blood flow in a dilated cardiomyopathy. Aortic insufficiency. Aortic insufficiency is illustrated using flow vectors with energy loss. Non-compaction cardiomyopathy is a rare congenital cardiomyopathy. VFM enables assessment of intraventricular flow efficiency and may be able to evaluate the severity of non-compaction of LV myocardium. Vorticity and streamlines of the vortex flow during the diastolic phase after mitral valve surgery clearly illustrate blood flow patterns. Post-mechanical or bioprosthetic valve surgery vortices demonstrate distinct vortex patterns based on the valve type and placement. In addition, mitral valveplasty physiological vortices can be evaluated post-surgery.